Good afternoon, everybody. My name is Julian Beltran. I am a philosophy professor at Fayetteville Technical Community College, and I am joining you today to welcome you to this event, Ethical Challenges in the Development and Distribution of a Vaccine for COVID-19. This event is a collaboration between the University of North Carolina, Chapel Hill, and their unit of Carolina Public Humanities in collaboration with Fayetteville Technical Community College. Today, we are honored to receive Dr. Douglas Paul Mackay. He holds a PhD in philosophy from the University of Toronto. Prior to joining the Department of Public Policy at the University of Chapel Hill, where he works, he started in 2013. He completed a postdoctoral fellowship in the Department of Bioethics at the National Institute of Health. His research and teaching interests concern questions at the intersection of justice and public policy. He's currently working on projects concerning the justice of economic equality, both domestic and global, the ethics of immigration, the immigration policy, the ethics of biomedical and policy research, and the ethics of health and welfare. Part of his recent publications are Ethics of Controlled Human Infection to Study COVID-19. This was a publication for Science magazine. 4 Phases of Fair Judge Subject Selection for the American Journal of Bioethics, and Geographic Location and Moral Arbitrariness in the Allocation of Donated Livers. This was a publication for the Journal of Law, Medicine, and Ethics. Please join me in welcoming Dr. Douglas Paul Mackay for his remarks on this very current issue of the morality of production and distribution of COVID-19 vaccines.
Great. Thanks very much for the introduction. Thanks to Fayetteville Technical Community College for hosting me, and also to Carolina Public Humanities for helping to organize the talk. I'm going to share my screen. So I have a number of slides that I'd like you to be able to see. All right, so I'm hoping everyone can see that. Yeah, so I'm going to talk today about a number of ethical challenges with respect to the COVID-19 vaccine, both on the side of the development of the vaccine and also the distribution of a COVID-19 vaccine, on the assumption that we are able to develop one that is safe and efficacious. So I'll start just by talking about ethical challenges in the development of the vaccine, and identify 3 or 4, I think, very difficult ethical questions that have arisen for investigators and policymakers. And then we'll look ahead to maybe, sometime in early 2021, when we might have a vaccine to distribute, and we're not going to have enough to go around for everyone in the United States, for everyone in the world who needs it. And so there'll be a lot of difficult questions around who should we prioritize, which populations should we prioritize. So just a little bit of background around vaccine development. So in general, there are a number of stages for developing a vaccine, including the COVID-19 vaccine. So usually we start with animal testing, where we give animals different doses of the vaccine to see if it leads to any adverse events, leads to any immune response. Then we move to human clinical trials, so offering the vaccine candidate to human beings. We start really small with what are called phase 1 trials. These tend to enroll around 10 to 100 healthy people. And we experiment with different doses of the vaccine to see if it leads to any adverse events. So the real goal of phase 1 trials are to ensure if the vaccine at different doses is safe for humans. Phase 2, we continue to be looking at safety, but we're doing it with a lot more people, hundreds instead of tens of healthy volunteers. And we're also now starting to look for an immune response. And then finally, with phase 3 trials, that's where we're doing real massive experimentation. A lot of the trials that are currently happening in the United States have over 30,000 people enrolled in them. And this is where we're randomizing people to either get the candidate vaccine or a placebo. And then we're trying to determine if the vaccine is protective against infection. The other thing that we're looking for with phase 3 trials is we're still trying to figure out if the vaccine is safe. And so we're looking for rare adverse events, right? Adverse events that might show up with a very small part of the population. And so only really show up where we have 30,000 people or more enrolled in the study. So in terms of vaccine approval, the Food and Drug Administration, the FDA, is responsible for ensuring the safety and efficacy of things like vaccines in the United States. And there's 2 levels of approval. There's the sort of standard level of approval, which is very rigorous and often takes a long time. And so oftentimes, we just talk about this as FDA approval or the licensure of a vaccine or a pharmaceutical product. The FDA in June 2020 outlined some guidance, and they're really looking for a vaccine candidate that's going to prove to be at least 50% efficacious or effective in phase 3 trials. There's a less rigorous form of approval that you may have heard of. It's been in the news quite a bit lately, and it's called emergency use authorization. The FDA just released some guidance earlier this month, and they're also looking for 50% efficacy in phase 3 trials. So this is going to be based on an interim analysis. So the studies that I'll talk about in a moment are really scheduled to run for 2 years, so a long time. And what's going to happen with emergency use authorization is, because we're in an emergency, we're in a pandemic, a vaccine is really needed right now. We're going to look sooner than we might have otherwise to see if there seems to be a positive effect from the vaccine using a kind of interim analysis. And on that basis, we might authorize the vaccine for use, perhaps limited use. So this level of authorization, it's quite a bit less rigorous compared to approval. And you only need to show, according to the recent guidance, that it's reasonable to believe that the vaccine may be effective. So we'll see if the FDA decides to authorize a vaccine using this mechanism. So in terms of vaccine development, where are we? So worldwide, there's a lot of candidates that are being studied right now. So the New York Times has a really good vaccine tracker. According to it, I checked this, just a few days ago. There's 31 vaccine candidates in phase 1 trials, 15 in phase 2 trials, 11 in phase 3 trials. 6 have been authorized already for early or limited use, but none in the United States. That's only right now in China and Russia. And there's real questions about the safety and efficacy of those vaccines that have been authorized. And so far, we don't have any that have been approved through like an FDA-like process. So what's happening in the United States? So we have a number of vaccines that are currently being studied in these big trials, phase 3, or some companies are running what they call phase 2/3 trials. So the 2 that I'll highlight here are Moderna and Pfizer. So these companies started phase 3 trials on the same day, July 27th, so midsummer. They have over 30,000 volunteers, and these are the ones that are sort of out front. So this really varies. So I think, depending on what day you look at the news and some of the analysis, there has been, an expectation that these companies might do a kind of interim analysis, maybe as early as later this month. Some people thought this could happen in October, or maybe in November. And perhaps if the vaccine looks like it's effective and safe, then they could apply for an emergency use authorization, perhaps later this year. So I don't have a great prediction on, when they're going to conduct this interim analysis. Basically, they need to reach a certain number of infections in order to be confident that the vaccine is protective. And at least as of today, they haven't reached that number of infections among volunteers. So just in terms of broader things happening, so the US is getting out front. They've purchased already 100 to 300 million doses from each company. So these doses are being manufactured. So the thought is, right, that one of these will prove to be effective and will already be in the process of manufacturing it, and it'll be ready to go as soon as possible. The best case scenario, this is from the Washington Post on October 21st, so a few days ago, is that there might be enough doses to immunize around 100 million people, maybe in the new year. So the thought is that we could have an emergency use authorization later this year, and then enough doses rolled out in early 2021. So I would say that's a judgment that someone in the know made a few days ago, but this is a really dynamic situation. Okay, so I've been brought here to talk about ethics, and so let's switch to thinking about the ethics of vaccine research. So there's a really prominent framework for thinking about the ethics of clinical research. It was put together by Ezekiel Emanuel, David Wendler, and Christine Grady in a paper just called "What Makes Clinical Research Ethical?" And they laid out 7 requirements for ethical clinical research. These have really stood the test of time. Most people who do work on the ethics of clinical research accept these as the appropriate standards, and much of the debate is now about how to interpret and apply them. So the first one, and you could almost think of these as a checklist, right? So if you're thinking about a particular study, you want to run through these and determine if you can sort of put a tick box next to them and say, yeah, the study satisfies this criterion. So the first one is called social value. So the idea here is that clinical research is expensive. It's often risky for participants. And so it's only going to be justifiable to carry out a particular study if it promises some value to society. So I think, COVID-19 vaccine trials definitely satisfy this in the sense that a vaccine is really, really necessary. Studies also need to be scientifically valid, right? So they need to meet good standards of scientific design. When we are deciding who to ask to enroll in studies, we need to make sure that we do so fairly. And I'm going to say a little bit more about this in a moment, because I think it's a really relevant criterion for thinking about COVID-19 vaccine trials. We also need to make sure that there's a favorable risk-benefit ratio, so that the risks to people who are participating in studies are outweighed either by benefits to them or some combination of benefits to participants and benefits to society. We also need to make sure that studies undergo independent review. So you might have heard of institutional review boards, or IRBs, or research ethics committees. So we need to make sure that any proposed study is reviewed by a third party to make sure that these criteria are satisfied. Also need to get informed consent. So if you've ever enrolled in a clinical study, right, you might have had to sign a form that has a lot of information about the purpose of the study, the risks of the study, the possible benefits, your rights as a research participant, and then you need to consent before you are enrolled in the study. And then finally, just a kind of vague principle called respect for potential enrolled subjects. And this will actually become important in a moment. one of the aspects of this is the idea that people can withdraw from a study anytime that they want. So they have a right to withdraw. Okay, so what are the features of these big phase 3 trials that have raised some ethical concerns? So one is around subject selection. So who we select, who we offer the opportunity to participate in research to has a really big impact on the distribution of the benefits and burdens of research. So one way you can see that is insofar as research participation is burdensome, it's risky, it takes up a lot of time, who enrolls has to bear the burden of that. But we also know that who we enroll in clinical research has a really big effect on who is likely to benefit from the study. So the idea is that if we want to generate knowledge that's going to be generalizable to a population such that we would feel confident that a particular vaccine or drug is safe and effective for a particular population, we need to make sure that representatives of that population are in the research trial. So one important aspect of fair subject selection is an idea of fair inclusion. So we need to make sure that the selection of research participants is sufficiently inclusive to ensure that the research can be expected to benefit everybody in society or important groups of people in society. The other aspect that's important to fair subject selection is called fair burden sharing. So the idea that participation in research is risky. It can involve a lot of time. It can involve a lot of discomfort insofar as you need to subject yourself to various testing, blood draws, and so on. And we want to make sure that it's not just one group in society that constantly is bearing the burden of participation, but rather this burden is shared more widely. So it turns out that in a lot of studies, but also with respect to these large phase 3 COVID-19 vaccine trials, these two principles, fair inclusion and fair burden sharing, yield conflicting imperatives. So imperatives that can be seen to conflict. So on the one hand, fair inclusion says, we want to make sure that we have a really diverse group of study participants so that we're confident that any vaccine that comes out of it is going to be safe and effective in everybody who needs it. On the other hand, fair burden sharing tells us that we want to enroll people who are best able to bear the burdens of research. So that might be people who are healthy, who are likely to face lower risks from having a new vaccine candidate put in their bodies. Maybe also people who aren't subject to socioeconomic disadvantage, right? People for whom it's easy to take time off work, go participate in the study. So on the one hand, fair inclusion tells us, let's be really broad in terms of the people we enroll. So we want to enroll racial and ethnic minorities. We want to enroll children. We want to enroll the elderly. We want to enroll people with comorbidities. We want to enroll pregnant women. Basically, anybody that we think we're going to give the vaccine to after we've studied it. On the other hand, fair burden sharing says we should be narrow, right? We should try to enroll people who are young, healthy, not subject to socioeconomic disadvantage. Francis Collins, who's the director of the NIH, he nicely illustrates this dilemma. He said, if this is a vaccine trial that enrolls a bunch of 20-somethings or white college graduates, it will not give us the information we need. So this set of conflicting imperatives, it's really kind of been a flashpoint for a number of populations. So the first is around the real need, and there's been a lot of push if you've seen media, advertisements. If you look at the trial sites for the various vaccines studies, there's a real emphasis on ensuring diversity. So there's a real need to enroll Black and Latino participants to ensure that the trial results are going to be generalizable to members of these groups who have been hit hardest by the pandemic. But on the level of burden sharing, there's a real question as to whether it's fair to ask members of these communities to bear the burdens of research. So they've already been incredibly burdened, disproportionately burdened by the pandemic. Oftentimes, members of these communities have limited access to healthcare, are subject to socioeconomic inequality and disadvantage. And there's also, in the history of the United States, prior research scandals involving people of color, such as the Tuskegee syphilis study, that has really led to mistrust among members of these communities for the research enterprise. So just to illustrate this, there's a great article in the New York Times, I won't be used as a guinea pig for white people, that came out on October 7th. And it followed around a woman, Carla Arnold, who's African-American woman, who is both recruiting people to be part of a COVID-19 vaccine study and is also herself a participant. So she has gone ahead and enrolled in the study. And so they were just following her as she went through neighborhoods in Pittsburgh, trying to get people to enroll in the study. So she said this: "I'm a proud African-American woman. As African-Americans, we always seem to get less out of things that go on. I want us at the forefront of this. I want to make sure that Black people are represented. I'm going by faith that these people, so the investigators, won't do to African-Americans what they did to us in Tuskegee." So you can see there's this reference to the Tuskegee syphilis study, which is a trial started in 1930, went all the way till the late 60s, early 70s. But that's still front of center in her mind. Another person interviewed in the story took a different perspective. She said, "I won't be used as a guinea pig for white people." And then yet another person, Rashawn Green, I think really emphasizes the need for fair burden sharing in terms of who is asked to enroll in the study. She said, now all of a sudden you come up with so it's just hard to see my slides with my video here. You come up with the vaccination and it's supposed to work and work well. And you want to try it on us. You haven't paid attention to us for years. If there's this great vaccination, something can remotely help someone and you're securing it. Why are you seeking out the African-American community? Why aren't you getting more of the 1%ers? Give it to Bill Gates, give it to Donald Trump. Someone like me, regular old people, every day trying to make it people will wait. You also see these conflicting imperatives, right? So the need on the one hand to have a broad, diverse group of participants, but also worried about risk that people might face and whether the burden of participation might be unfairly imposed with respect to the elderly, with respect to children, and also with respect to women who are pregnant or breastfeeding. So the elderly, the studies look pretty good in terms of the elderly, though there are some studies with age exclusions. So maybe people above 85 are not allowed to participate. Only one study, the Pfizer study, enrolls people younger than 18. So it enrolls people who are 12 and older. And all studies are currently excluding women who are pregnant or breastfeeding. And there's a couple of bioethicists, Angela Ballantyne and Francois Baylis, who made it really, I think, a strong argument that pregnant women who are breastfeeding should not be included from these studies if we're going to expect to give them the vaccine after it's developed. So they say, exclusion from research does not dodge the risk of unproven vaccinations. It simply shifts this risk from a carefully monitored clinical trial to the privacy of a doctor's office. Excluding pregnant women from vaccine research is both unjust and imprudent from a public health perspective. So their idea is that, look, if we're concerned about the risk of enrolling pregnant women or young children or very elderly people in these large phase 3 studies, that risk is going to be borne at some point. So it's going to be borne later when we are offering the vaccine to them and it hasn't been tested on someone like them. And so what's the point of doing that? It's better to do it in the study where there's a lot more oversight. People are being followed more closely. Another issue that comes up and people have just started to talk about, so there's a couple of news reports that you might have seen around this, is whether the FDA should issue an emergency use authorization and what happens if it does, right? So first, imagine that maybe in the next month or so, November, December, the FDA says, yep, we're confident that there's a reasonable chance this vaccine is going to be effective and safe. And so we're going to issue an emergency use authorization. What then happens, right? So now you have a vaccine that's going to be available to millions of people. Is it then still ethical to continue conducting these placebo-controlled phase 3 studies where some people are being randomized to a vaccine candidate that hasn't been proven, and others are going to be randomized to a placebo? So first of all, for the phase 3 study on the vaccine that has now received this authorization, should participants in the control arm, so should participants who are getting the placebo now receive the vaccine, right? Should other vaccine studies be unblinded? So what happens in these big studies is the investigators don't know, and the participants don't know whether they've received the placebo, whether they've received the vaccine. And so you can imagine, and maybe there's a good argument from the idea of respecting enrolled subjects, that if you're a participant in, say, the Moderna study, and the Pfizer vaccine has just been authorized, you might want to know if you've been given the placebo or if you've been given the Moderna vaccine candidate, right? Particularly if there's a chance that you could access the vaccine that's been authorized. What might happen, right? People have a right to withdraw from studies, so you might just see a lot of people withdrawing from other big trials that are happening if they have a chance of getting the authorized vaccine. So there's another ethical question, even if some people are willing to participate, is it still okay to continue the study, knowing that there's at least authorized vaccine that's available to people? So is it still okay to give people a placebo, right? Bigger question I think the FDA is going to face, and there's already been a lot of debate and dialogue about this, it's going to continue, is given all these problems, should the FDA just hold off on issuing an emergency use authorization? So part of the worry here is that the FDA is going to issue an emergency use authorization. And then from that point on, right, so this is going to be a vaccine that we haven't studied as much as we want to. We haven't followed up on safety as much as we want to. It hasn't been approved. And that's going to be the vaccine we're going to have for a long time. Maybe it's just above the 50% efficacy threshold. It's possible some of the other ones that we're studying would be better. And the problem is that once we authorize one, it's going to be very hard to justifiably run placebo-controlled trials where we're going to be evaluating the other ones. People just might not even enroll in them. Okay. Another big topic that you might have seen and that has received a lot of attention is the possibility of human challenge studies. So these are studies, they involve typically a very small number of participants, so oftentimes between maybe 10 and 100 people. And they're deliberately exposed to a pathogen to study how infection works in the body, and oftentimes to gather preliminary data on an experimental vaccine. So we do this often with the flu, we do this often with malaria and cholera. And one thought is with COVID-19 is that we could expose some volunteers in sort of an inpatient hospital unit where they're isolated. We could give them the vaccine. A few weeks later, once we think that it's working or potentially working in their bodies, we could then deliberately expose them to COVID-19 and see if the vaccine is effective, right? The reason we might want to do this is to really speed up the process. So with these big phase 3 trials, we have to randomize people to get the vaccine, randomize people to get the placebo, and then send them off into the world. And then only once a certain number of are infected will we have data. With this, we're directly exposing them to the infection. One reason this is controversial, I'll come back to this in a moment, is that in contrast to these other pathogens and diseases, things like influenza, malaria, and cholera, we are not confident that we can fully treat someone with COVID-19 and save their life. So there's a real worry on the side of investigators that they're going to deliberately expose someone to COVID-19 and they're going to pass away, right? Or develop just very severe symptoms and maybe be one of these people who has symptoms for the rest of their life, right? Might have heart damage or something like this. There's currently a proposal to start these studies in the United Kingdom. So the proposal is not to test a vaccine this way just yet. They want to enroll 30 to 50 people in a study. They'll be young, so the thought is the risk is lower in terms of the developing the illness. It's going to take place in an isolation unit in London, and they want to identify the dose at which the virus infects participants. And then once they do that, they're going to use that to evaluate vaccines in the future. So this is something that's been proposed. It still needs to be okayed by regulators and ethical review boards, but that's a concrete example of a challenge study that's on the table at least. What are the chief ethical considerations for challenge studies? So the big one is social value. So the real promise of these studies is to speed up the development of a vaccine. This is going to save lives. It's going to also just, particularly in low-income countries, if we can get a vaccine sooner rather than later, it's going to prevent people or limit people from falling into poverty for too long, right? So even in the United States, the pandemic has been economically devastating for people. And so just think of the good you could do if you have a vaccine quicker, right? There's a group called onedaysooner.org. This is a group that really touts the benefits of challenge studies. And they say, look, if we just get a vaccine one day sooner through challenge studies, that's going to save still a large number of lives. You can volunteer for a challenge study there. I'm not taking a position, I'm not advocating you do this, but I'm just noting that this is a group that exists. And they have almost 40,000 volunteers who have signed up to participate in challenge studies. Were these studies to run? Some people doubt the social value. Some people say, look, we're already studying these vaccine candidates in phase 3 trials. We don't need to speed things up. We actually can't speed things up with these challenge studies, and so there's no reason to run them. The other big worries are around whether the risk is too much. So as I mentioned, the challenge studies that we've done in the past have been ones where we're confident that we can fully treat someone who develops symptoms or who develops, a severe infection. We're not confident with COVID-19. And so you have to be, there's a big question about whether that's an acceptable risk that we're willing to allow members of our community to take to benefit other people. You also need to find investigators who are willing to expose people to the virus, knowing that might severely harm or kill them. The other piece of this is around informed consent. And there's this worry around something called undue influence. The idea that if there's a lot of payment, a high payment associated with participation in challenge studies, people will sort of jump at the chance to participate and not think through all of the long-term costs and risks of being exposed to the virus. And so there's a question about how we ensured that informed consent is actually given for participation in these studies. Okay, so I'm going to sum up just the first part of the talk. The next part will be a bit shorter. And this, 3 ethical issues having to do with the development of a vaccine. So one is, should we opt for more inclusive studies, even if this means enrolling people who might face higher risks, even if it means recruiting people from communities who have been hit hardest by the pandemic and who are disadvantaged in a number of ways? Second question, what should we do if we're in a position to maybe issue an emergency use authorization? Should we do so? If we do so, do we need to then, with respect to the trials that are ongoing, start to unblind them, be honest with people about whether they've received the placebo or not? And then finally, is it acceptable to deliberately expose young, healthy volunteers to the virus in order to accelerate the development of a vaccine? Okay. So the next part of the talk and the final part of the talk has to do with distribution. So let's suppose, right, we get maybe an emergency use authorization in January or February or maybe March 2021. We have maybe 50 million doses or 100 million doses. Who should get priority, right? How should we decide who should get those vaccines first? One side of this question is domestic distribution. So insofar as it's one of the vaccines that the United States has purchased, millions of doses of, how should we distribute it in the context of the United States? Another question, though, is an international question. So a lot of countries, low-income countries, middle-income countries, might have been pretty hard hit by the pandemic, could really benefit from having a vaccine, but they might not have the resources to purchase as many doses as necessary. And so for high-income countries like the United States, they can afford to purchase vaccines for everybody. But does the US, does Canada, does the United Kingdom, do other high-income countries have an obligation to ensure that people in low and middle-income countries can also get access to a vaccine? Okay, so let's look at the first question first. So this is a question of distributive justice, and there's a number of principles that people have cited and made use of to think through this type of question. One principle is the principle of beneficence, the idea that we want to do the most good in the world and promote and prevent the most harm. So when we have a scarce resource, we should allocate it in the way that is going to, in the case of the pandemic, prevent as much death and illness as possible, alleviate as much socioeconomic harm as possible. There's also a principle called priority to the worse off. So the idea that when we have a scarce resource, we should give priority to those people who have been disadvantaged, whether this means that they're at the greatest risk of suffering socioeconomic harms, or they're at the most risk of illness, of developing illness. Another principle is the idea of equal concern, the idea that we shouldn't be treating people differently on the basis of morally irrelevant characteristics. So the idea that when we're distributing a vaccine, we don't want to discriminate against anybody on the base of things like sex, race, ethnicity, and so on. And then finally, a principle that not everyone is on board with, but I think is sort of interesting to think about, is the idea of reciprocity. So in the context of allocating a scarce COVID vaccine, should people who have participated in clinical studies get priority, some sort of priority, right? So the idea is they've made a contribution to the public effort to develop a vaccine. Should they get some priority? Should we reciprocate by giving them priority in the distribution? Okay, so in terms of the domestic process, we're actually pretty far along in coming up with a plan. So right now, we're still waiting for a decision from the FDA. I don't know when that's going to happen, as I mentioned. But once the FDA either authorizes or approves a vaccine that the US government has sort of purchased, has access to, the Centers for Disease Control and Prevention will then decide whether they should recommend it for the population and say some broad things about which population should receive priority. States then will take over and will be responsible for allocating the COVID-19 vaccine to their populations. And so states actually submitted plans for allocation October 16th. What I have to show you here is just a sort of summary of North Carolina's distribution plan. It's a 4-phase plan, so they see it as sort of proceeding in phases. And if you want to take a look at this, it's quite detailed, it's quite thorough. It should be available on the North Carolina Institute of Medicine website. So this is a publicly available document if you want to take a look at it and read it. So the first phase of the plan is to basically give the vaccine to healthcare workers and medical first responders. And the goal here is to really stabilize the healthcare system, so we don't run the risk of what we're in danger of right now in some US states, and also in danger of, it looks like in some countries in Europe, of having so many COVID patients come to the hospital that the health system is overrun, and that people, physicians, nurses are becoming infected and can't work. So we want to preserve the health system first. And so most plans give priority to frontline healthcare workers and medical first responders. That's estimated to be around 150,000 people in North Carolina. The other population in phase 1 is people who are at really high risk of mortality if they are infected with the coronavirus. So these are people who are residents of long-term care settings, people with 2 or more chronic conditions, so people who have comorbidities that are likely to increase the risk of death or severe morbidity if they're infected. People over 65 in congregate settings, so settings in which it's hard to social distance. So this includes prisons, migrant farm camps, and homeless shelters. And so this is estimated to be, anywhere between 700,000 and 950,000 people. Second phase, aim there is to reduce transmission. And so here we're going to prioritize people who are at the highest risk of exposure and transmission. So again, people in congregate living situations, frontline workers, other healthcare workers, and also people who are at greater risk of passing away, developing severe illnesses if they're infected. So this is adults with 1 chronic condition and elderly people, people over 65. Phase 3 is any remaining frontline workers. And you can actually, if you look at the plan, they sort of provide examples of what they mean for each of these groups. And focusing in particular on people critical to societal functioning, also K-12 and college students. And then finally, a big group, which will just be the remaining population. So what are the points of contention? So this is the plan that North Carolina is currently running with. What are some of the ethical issues or issues that are contentious that maybe we want to reflect on a little bit more? So one big issue that I think is important to think about is, and it nicely connects both parts of this talk. One worry is that if we're prioritizing people who are elderly, if we're prioritizing people who have various comorbidities, chronic conditions, have we actually studied the effects of the vaccine on those people in the clinical trials? So I think there's a worry if we've excluded those folks from participation in clinical trials, we then want to prioritize them in access to receive the vaccine. There's a real question about whether that is going to be safe and effective for those people. Another issue that's left out of the prioritization plan is whether research participants should be prioritized on grounds of reciprocity or not. And then finally, another point of contention is whether healthy people over 65 who are in phase 2 should get priority over people who might really benefit a lot from being able to go out and live their lives as they could before. So the idea here is that it could be that healthy people over 65, at least some of them are able to shelter in place, maybe they're retired. By contrast, a lot of K-12 students, university students, people who are working in industries critical to social functioning, they're really suffering, both in terms of pay, in terms of lack of access of in-person schooling. And so you might make an argument, well, maybe we can do more good by focusing on those people. One other big point of contention is how to think about whether there should be direct priority given to members of groups who have been really disproportionately harmed in the context of the pandemic. So in the context of North Carolina, more broadly in the United States, it's been low-income essential workers, Black Americans, Latino Americans, who have really borne the brunt of the pandemic. They have higher rates of death, higher rates of infection. And so some people have argued that those are the groups that should be prioritized. So we should maybe give priority to health workers and then give direct priority as sort of phase two to members of these groups, people who have been both structurally disadvantaged and historically disadvantaged in the United States. There's a couple of concerns with this. So one concern people have raised is just whether allocating on the basis of race or ethnicity would sort of pass legal muster in the United States. Some people have said as an alternative that instead of doing sort of direct allocation on that basis, you could use something like the Social Vulnerability Index. So this is a way of measuring how vulnerable different areas of the United States are, and you could allocate to those communities that are most vulnerable. Another concern that's been raised with this plan, again, goes back to the research phase. So remember this quote, right, from this woman who's resisting participating in a clinical trial. She said, "I won't be used as a guinea pig for white people." And some people worry that if you have a vaccine that has been received emergency use authorization, but it hasn't actually gone through the full FDA approval, it kind of looks like you're just, and then you're going to give priority to communities of color, then it just looks like you are sort of experimenting on those communities. And it raises all of these sort of issues that have happened in US history around the exploitation of these communities in research previously. The one thing I wanted to say just about the North Carolina plan. So in the text of the plan, the authors are very conscious of this concern, and they see their, insofar as their proposal gives priority to really frontline workers, essential workers, they think that it will indirectly give priority to communities of color and people who are low income. And so they're conscious of this concern, and that's at least how they see the way forward in terms of addressing it. Okay, what about global vaccine allocation? So remember, we have this second question around which countries should receive priority in the allocation of a COVID-19 vaccine. And I think more generally, does the US have an obligation to cooperate here? Does the US have an obligation to try to make sure that people in low and middle income countries can afford a vaccine? So one answer to this question is just no, right? This is a position that's come to be known as vaccine nationalism. And so the idea is that states are on their own. States should look out for their own citizens. They're responsible for trying to get enough vaccine doses for their citizens. And if other countries can't get vaccines because they're too expensive or whatever, that's just too bad. That's not the only position that's been developed. And actually, there's a huge movement, international movement, to go in a completely different route. So there's something called the COVAX facility. This is a global collaboration led by Gavi, the Coalition for Epidemic Preparedness and Innovations, and the World Health Organization. And it's really a platform where these groups and countries can come together, make collective purchases of vaccines. Currently, they have about 11 vaccines in their portfolio, so a really broad portfolio of potentially effective vaccines. And then they are doing some sort of resource sharing to make sure that low-income countries will have subsidized access to any vaccine that proves effective. So right now, there's about 183 countries who have committed to or are interested in participating in the COVAX facility. In terms of allocation, they're going to do it by population. So COVAX, they want to have 2 billion doses available by the end of 2021. And what they're going to do is once they have safe and effective doses of the COVID-19 vaccine, they're going to basically allocate among member states equally. So they're going to allocate proportional to population the same number of doses. So they're not going to, allocate, as the next view I'll look at will propose, based on who needs the vaccine the most. As of September 1st, the United States has decided not to participate in the COVAX facility. And the reasoning that was given by a spokesperson is that it does not want to be constrained by multilateral organizations influenced by the corrupt World Health Organization in China. One thing to note here is that some public health scholars have worried about this decision, both because of fairness concerns, right? So you might think we have strong obligations to people in low and income countries. We should play some role of trying to ensure they get access to a COVID-19 vaccine. But others see it as sort of the US removing itself from a sort of useful insurance policy, right? So the US has purchased vaccines already from 5 or 6 companies. But if none of those pan out, if none of those work, this looks like a pretty good insurance system, that you've had access now to a broader portfolio of vaccines, and you'd be at least getting some of those that were effective. There's another model out there, and I won't go through this too much because we're running a little short on time. It's called the fair priority model, and it also makes use of these principles that were used in the domestic distribution, beneficence, priority to the worse off, and equal concern. And it suggests a different way to go. So rather than distributing equally, you might say, they want to say we should have COVAX distribute vaccines equitably, so based on need. So they propose a 3-phase distribution, where the first phase is allocating vaccines to those countries where we can do the most good in terms of reducing life years lost and preventing deaths. Then we want to turn to, once we've done that, to reducing serious economic and social deprivations, so combating severe poverty and so on. And then finally, once we've addressed that, then we'll give priority to countries with higher transmission rates. So this is a very different plan. So instead of just allocating vaccines equally to the members of COVAX, regardless of what's happening in their countries, this is really saying we're going to put the vaccines where we can do the most good, either in terms of saving lives and preventing illness, or in terms of combating poverty. And so there might be a really strong priority here to give it to countries with high infection rates and severe economic disruption, from a really low base, such that a lot of people are really being put into deep poverty, living off $1 or $2 a day. So some points of contention. So, one way of thinking about the trade-off here is, should vaccines be distributed equally, which is the COVAX plan currently, or equity, which is the fair priority model? On the one hand, the equitable distribution promises to do the most good. On the other hand, I think one reason for favoring the equal distribution is, you might say, don't countries have some responsibility for the level of outbreaks they have, right? So some countries, right? So Vietnam, for example, has done incredibly well in controlling the infection. The United States has not done that great, right? Is it okay for the United States to come in and say, look, we have a lot of infection here. We should get priority over Vietnam for the doses that are available, right? Vietnam might want to say, look, we should get equal amount of doses per population, and we shouldn't be penalized because we've taken good responsibility for addressing the pandemic. I think there's another practical issue here, which is whether high-income countries would agree to participate in COVAX if it was equitable distribution. So I think that, if they were going to go by the fair priority model, a lot of the vaccines would probably go to countries that have a lot of poverty, have been hit tremendously hard by the pandemic, and high-income countries just might not get that many doses. And so high-income countries might be saying, yeah, we're a little bit altruistic. We want to help out low-income countries, but we still want to protect our interests. And so we will only agree to participate in COVAX if there's an equal distribution, if we're guaranteed to get something. Okay, so let me finish up. So I'd say a couple things. First thing is that science is incredibly important for development of a vaccine in particular. So really important what scientists are doing. But I do think that both when it comes to the development of a vaccine, the distribution of a vaccine, there's a number of challenging ethical problems that we need to work through and that we need to take positions on. So one set of issues is around how we treat people who are enrolled in research, what kind of studies we want to plan. The other is, how do we distribute this scarce resource if we don't have enough vaccines to go around? The remaining question I haven't addressed, and that we'll face once vaccines show up, is will people take it, right? If you look at polling right now in the United States, it's not reassuring how many people are actually reporting being willing to accept a vaccine. There's another further question, a question that we've addressed with other vaccines around whether you can mandate people to take a vaccine. So, would it be okay once we have enough vaccines around for all school children to maybe next September, if we're lucky, to say, look, you can only go to school if you have had a COVID-19 vaccine. So that's sort of a set of further questions that we're going to be addressing, even once we've solved these two questions that I've talked about today.
Thank you so much, Dr. Mackay, for this very, very enlightening analysis and reflection on the ethical issues that are associated with the issues of COVID-19 and the pandemic. Let me remind you that you can submit your questions with the button Q&A at the bottom part of your screen. And there is a lot of questions that are coming, gravitating around a very logical issue, a very obvious issue that people are asking about, and is, should we, and if we should, how can we isolate these scientific decisions from the political background?
Yeah.
Should we do that kind of isolation? And if we do it, how should we do that?
Yeah. I'm definitely in favor of isolating scientific decisions from political influence. I think that we might have thought that we'd sort of address that issue in the United States insofar as we had the FDA and the CDC as sort of fairly independent agencies, as well as the NIH. But there's been some political pressure, right, from the White House, from the administration, some of them with respect to the authorization of some of these other therapeutics that were authorized by the FDA and don't look like they were effective or really based on great evidence. Just before coming on, I saw in my Twitter feed that there's a new report coming out that is raising questions about the process by which this happened, by which the FDA authorized these things, if there's undue influence from the political sphere. So I think going forward, the big pharmaceutical companies have said, like, we're not going to release anything that isn't safe and effective. The FDA recently, with its October guidance on an emergency use authorization, took a kind of at least a minimally strong line. There was some real pressure to try to get a vaccine authorized before the election. And they basically said, no, that's not going to happen. We want to wait a certain period of time to make sure things are safe. And so, that really put back any authorization till after the election. What I would advise people is just to try to find, try to be, I think, have a healthy dose of skepticism when these decisions are made. Read widely, see what experts are saying, see if, people like Dr. Fauci are recommending that this is, the process has gone well, that that these things are safe and effective. So, I think I would say be skeptical, but I think there's good people at the FDA, there's good people at the CDC, there's good people at the North Carolina Institute of Medicine that we can trust and that really have the public interest at heart.
There's also a kind of a technical question on how do we move from phase to phase. So it's clear that there are, and of course, first responders and people in the healthcare area, they are going to be given priority. And part of this priority, and it is safe to assume that they are aware of the importance of being vaccinated. But in the subsequent phases, there might be some population that is reluctant to receive this. So do they have, like the ones that might not be over 65 or with comorbidities waiting for this vaccine, will they have to wait until these people waive their participation in a possible vaccine?
Yeah, I'm not sure. I mean, I think that, the plans are out for the allocation, and I think there will be some waiting. I don't know how many doses we're going to get at first, but probably they're gonna offer it to healthcare workers, probably doing the vaccinations maybe in the hospitals, in the clinics where they're working, and then also going out to these long-term care homes. And then the other forms of distribution will be sort of broader out in society. Some of us will get it in our doctor's offices. And so, I don't have a great sense. I don't know if anyone has a great sense about how many doses could be available in like January or February or March, but I don't think it's going to be terribly many. I think that there's going to be a long drawn out process where we move through different populations and people have different access to the vaccine.
There's this other perspective, because your talk and your presentation has focused a lot on institutional responsibilities and institutional obligations that are connected with this. But could you share with us some moral principles that could be applied to clarify the moral responsibility of the general population? Can we talk about some obligation of the public in these terms and some moral concepts that can illustrate that obligation?
Yeah, I mean, I think that there's sort of a moral principle called the duty to rescue, right? That is widely accepted, has been around for a long time, and the idea is that if we can prevent something bad from happening with very little cost to ourselves, right, we ought to do it, right? So the thought experiment people often use, right, is you're walking through a neighborhood and there's a toddler who's fallen into a pond or into a pool of some kind. Do you have an obligation to like wade in and pull the kid out and save the kid's life, right? And do you have an obligation even if you just bought a really nice pair of leather shoes, right? And you're going to ruin your shoes by walking into the water. Most people say, yeah, of course you have an obligation to save a life, right? You can prevent something bad from happening without really imposing big costs on yourself. So I think for most people, for whom like taking a vaccine is, and let's, assuming that the vaccine is safe and effective, approved by the FDA in the proper way, taking a vaccine will be kind of like wearing a mask, right? It's going to be a way of preventing yourself from harming other people. It's going to be preventing bad things from happening to other people. And the cost to you is very, very minimal. I think, we don't usually think about being able to harm someone else by not getting a vaccination, but with infectious disease, right, that's a way that we can really severely harm someone else. And so I think that when it comes to each of us, there's a good argument that insofar as not getting vaccinated poses a risk of infection to somebody else, which can be quite damaging, then you have a moral obligation to get vaccinated. In the same way that we think we have a moral obligation to wear a mask.
There are some questions because, of course, part of the healthy skepticism that we are considering in political terms, there are also some possibilities of healthy skepticism in economic terms.
Right.
So there are some questions about how much we should be focused or how much should we pay attention to the sources of funding of these vaccines. So if there are economic groups that are behind funding, how much should these be part of the calculations that people do in making these decisions?
Yeah, I mean, yeah, I haven't looked into it too much. I think it's all those things are worth looking into, right? My understanding is that the United States is going to provide the vaccines free to people in the United States. But they're spending billions of dollars to purchase vaccines from companies. And so, just part of thinking about ethics is recognizing conflicts of interest. And, pharmaceutical companies have an interest in making a lot of money. And so we, think about like, Purdue Pharma, right? And selling opioids, misinforming the public about them, and just leading to, the ruin of a lot of lives, right? In terms of addiction, death, overdoses, and so on. And so I think, that's another area where there should be some healthy skepticism to make sure that, the way in which these things are being tested are being tested properly, that we can trust the data, and all of those things. So I would say, like, I'm hopefully, I'm a little bit confident that there's enough oversight and enough scrutiny of the development of these vaccines that when it comes to the FDA authorizing something, we'll have a lot of information and a lot of analysis to make informed decisions about whether it's been either overly politicized, it's being pushed out too fast, or whether it, there's been something dodgy on the part of the pharmaceutical companies. My sense is that there'll be enough analysis and transparency that we can make good decisions. That's my hope, anyway, I would say.
There are a couple questions about distribution. The first one going into how much, what would be the responsibilities, or what would be the obligations or the possibilities, the decisions that are going to be taken about allocation of doses for undocumented immigrants or for U.S. citizens. If there's any kind of legal principle that should be taken into account here.
Yeah. So that's something I should have looked at, actually, and I didn't look. I have looked at the North Carolina plan, and I didn't look terribly carefully on that particular issue. So that's something I would like to go and revisit. I do know that I was involved a little bit with the process by which North Carolina Institute of Medicine came up with a ventilator allocation plan back in March and April. And there it was just taken for granted that there would be no differential treatment on the basis of immigration status. And so, there wouldn't be a situation where someone who didn't have insurance, someone who was an undocumented immigrant, would be denied care or would be deprioritized care in favor of a U.S. citizen. And so my guess is that's going to be the same at the state level. I think there is a sort of broader discussion, political discussion, ethical discussion about whether the U.S. government, state governments have an obligation to provide undocumented immigrants with health insurance. That's sort of a dividing line between some Democrats and some Republicans. And so there's sort of a broader debate to be had there. But I think when it comes to infectious disease, you're just going to, not vaccinating some portion of the population is just prudentially a bad idea, right? So even if you're not motivated by ethical concerns, you want to make sure that as many people as possible within your community are vaccinated to ensure herd immunity. And so I think that on this question, both ethics and prudence thankfully go together.
What about the military? Do you know if there's going to be any mandatory measure for the military?
Yeah, I didn't see anything, but that's another great question. And yeah, I'm sorry I don't have a lot of answers to these questions. They're great questions. You know, I would just, it's possible that the military would just be in a separate category and that they would have a separate source of vaccines that would be allocated among people in the service. That would be my guess. But it's a good question. I'm not sure exactly what the answer is to that question.
Now, there's this other section of our questions that interestingly are asked anonymously. Okay. And of course, I think that part of the success of academic reflection is also in the consideration of some of the possible issues that are presented here. So are vaccines, and in any way, is there any kind of evidence of hard evidence of a correlation between vaccines and autism? Right. Or any kind of reluctance of people in the healthcare area to not to discuss the effects of vaccines in children?
Yeah. So, you know, I'm not a medical doctor. I trust the medical experts that I speak with, and I think that the broad community, in terms of like, if you're going to poll medical experts, they think that those studies have been debunked. That doesn't mean that like vaccines don't have any risks. I think that, you know, I'm not aware yet of any serious adverse events that people have suffered from having a vaccine, a COVID-19 vaccine, but there could be some. I think with everything, you know, with a lot of medical treatments, it's all sort of about the risk benefit, right? That yes, there could be some risks from taking a vaccine. That's part of the reason why we want to do these massive studies before we roll it out to the population. But it still might be the case that comparing the risks and benefits, it's still a great idea for people to get a vaccination.
And of course, there are some remarks on the impact that these measures of after the pandemic and the morality of this, like keeping children from going to school, or how businesses have been hardly affected by the entire thing. So maybe there is an ethical principle that we can connect with this topic.
Yeah, I mean, I think, you know, there's a lot of good work that's been done on the sort of thinking about the ethics of vaccination, and particularly not from sort of I mean, I mentioned the duty to rescue as a sort of principle for individuals. Often as we talk about the harm principle in the context of vaccination, that, you know, the idea is that government is entitled to interfere with people's liberty to prevent you from harming others. And so some people rely on that as a justification for mandatory vaccines, right? So that if you going unvaccinated really imposes risks of serious illness or death on somebody else, government can step in and mandate that people take a vaccine. And in the context potentially of a school setting, or that's sort of one way in which sort of making that happen. You know, I think so I would say, like, you know, given how politicized things are right now, given how politicized the development of the vaccine has been, given current polling, you know, I think it's around 50% people are saying that they will take a vaccine or not take a vaccine. I would say there's going to be, once something becomes available, how it becomes available, there's going to be a lot of discussions that we still need to have, a lot of difficult ethical questions about, particularly, if you think about this being a new vaccine, right? That potentially has not gone through all of the rigorous testing that other vaccines that we commonly use have gone through. And there can be, legitimate reasons to be skeptical, legitimate reasons to say that you're worried about, having yourself getting it or your children getting it, right? So, for myself, I'll definitely take think very carefully about if and when my 3 children become vaccinated, right? Or if I become vaccinated. There's just a lot of uncertainty right now. And my hope is that when we get something that's authorized, if we get something that's approved, we'd have, had the scientists taking a look, making very careful, non-politicized judgments about risk, benefit, safety, and efficacy. And then we have clear communication, right, about this to the public.
Naturally, we could have an entire semester of discussions about the morality of ethics, the pandemic, lockdowns, and several others. Several universities actually are already underway with interesting classes on these topics. And of course, our availability of time is limited. We are going to extend some of these questions to Dr. Mackay to maybe we will have the chance to tackle that maybe in an email. But we definitely appreciate and we thank you very much for your remarks and your reflections on this very difficult issue. I think that this is one of those interesting moments in which philosophy has the possibility to step in a more unbiased process, asking difficult questions to shed light on what we are doing. There are other sciences that are political and economic interests that are trying to come up with answers because they might be promoting different answers, but it is the task of philosophy to promote the questions. So the reflection is alive, the discussion is alive, and we can keep a check on perspectives that might be biased.
Yeah, that's great. I was really glad to do this. I wish I could see people's faces, and I hope this was a little bit enlightening and useful for you. Yeah, I would just second that last comment that, this has really been a time when I've seen philosophers consulted on things, on really important, difficult issues of public policy. There's philosophers active in developing guidance on ventilator allocation, philosophers active in the development of the North Carolina allocation plan, and philosophers active in the development of all these allocation plans that I've talked about today. And so, it's not often the most practical discipline, but there's definitely a lot of policy relevance and importance for this type of thinking, this type of training.
And we thank you very much for your philosophical perspective and your philosophical contribution to this topic. To all the participants, thank you so much for taking the time to listen to some of these things, to engage in your questions, and let's keep an eye on this, having an unbiased perspective and something that, of course, all of us carry a huge responsibility. Thank you very much.